exam 3, your last exam for pediatrics before the HESI. A lot of information. So I did make the PowerPoint. I went over it with a fine-tooth comb, added more pictures, did all the things I do to it because it's never the same. Making sure that the information you need is there for not only exam, but also for your HESI that comes up. So when you're looking at these, this information, remember, it's also a good review to go over these reviews for exam 1, 2, and 3 for your HESI, because all the information is covered, okay? Just a little hint, okay? So let's start with the endocrine system, and let's go over the diabetes. Now, when you have diabetes, we know it's your body's inability to digest carbohydrates. It's no insulin. Your pancreas is being attacked. The cells are not producing the insulin it needs. So we have sugar in the blood. And that's hyperglycemia. That's just sugar in the blood. We know what we first start to see is you're thirsty, you're urinating a lot, you're hungry, and you literally are losing weight because your body has no sugar. Now, what happens also is some of these children with diabetes start bedwetting at night with this enuresis. So diabetes, the hyperglycemia, is basically the insulin's not there, sugar's in the blood, that is hyperglycemia. Now, when you start seeing to the point where your blood sugars go really high, and we start seeing the body says, you know, I'm really hungry. Let me try another food source. So let's go to the proteins. So it starts eating protein for food, and what happens? Ketones are formed. So that's when you start seeing the ketoacidosis. So the difference is hyperglycemia is the blood sugar is elevated, which can happen anytime in a child or a patient with diabetes. It's when we get to the DKA, diabetic ketoacidosis or ketoacidosis, that is the presence of ketones in your urine. This is a time where you're going to see the child looking pale, drowsy, and then you're going to smell this fruit. And I said it smells like a rotten peach in a container that you open it up and you get that smell of sickening sweet. That's what it really, really smells like. So that's the difference between hyperglycemia and ketoacidosis and what the body does very simply and what you'll see. So we know that hypoglycemia is when your body doesn't have enough sugar in it. So it could be you're diabetic, you're taking insulin, you didn't eat, and now your body has no sugar. So what you will have a child or an adult feel: nausea, vomiting, jittering, sweaty, not feeling too good. Now, if a child is complaining, that means they're alert enough to drink. Give them something to raise their sugar right away. Orange juice works, milk, give a sugar packet, something, hard candy, something to give them to increase that blood sugar right away. It's all you need to do. You don't need to do anything more with hypoglycemia with a child telling them they don't feel good to give them something. All right, let's go to the pituitary gland. Now, we know the pituitary gland has two lobes, the anterior lobe and the posterior lobe, and they both secrete different sort of hormones. We know that there is one lobe that does produce hormones that result in growth. So whether you're too much, hyperpituitarism, which means that's gigantism, I mean, you're just really big and tall. I mean, 8 feet tall you could be if we don't take care of it. Usually this is due to a tumor. And if they remove the tumor, you'll usually go back to your proper growth patterns. Then there is hypopituitarism, which means you don't have enough growth hormone. What will you see? You'll see a kid who's really small, short. This is a time where parents might decide to say, we want to give our child a chance to be at least 4'8". So let's give them some hormones. And it is a subcutaneous injection. So it is daily most of the time. So these hormones will help a child grow. And what we will see with this child, how do we know it works? Well, we know that the child getting growth hormone, we will see them growing. They'll get taller, which is just an outcome. It's that easy as that. And just because a child is short doesn't mean that it is a deficiency of growth hormone. It could just mean that that child is from a short family, that child will be short also. And again, that sometimes it can be due to the hyper, could be due to the tumor, the hypopituitaryism, just maybe you'll need some little bit of growth hormone. So another type of hormone that can be produced is for puberty. And we know precocious puberty is basically only the development of secondary sex characteristics at an early age. It means going through puberty at age 6, getting breast buds, at 6 years old. Boys at 6 growing hair on their face. This is a sign of it and what we would know about. And we can suppress that also with medications. Diabetes insipidus is the secretion of a hormone that causes polyuria polydipsia, which means what? You're going to be drinking a lot, you're going to be urinating a lot, you go into real severe electrolyte imbalances. So because of that, we monitor for dehydration because you're drinking and you're urinating. And it is with this one, what we need to do is monitor the vital signs, and we need to stop this progression. We give vasopressin, which is stops it. And we know the vasopressin worked when the urine stops, the thirst stops, right? Syndrome of inappropriate antidiuretic hormone. So antidiuretic hormone, anti-urinating. So if we have a child that's not urinating, what will you see? Well, they've got fluid in their body. So it's going to be there. So we're going to see a child gaining weight with fluid, and we're going to see a child getting puffy and edematous. How do we treat that? Well, whenever you have fluid overload, you're going to restrict the fluid, and you're also going to restrict the salt intake. What will be your appropriate nursing action for the SIDH, this hormone? Well, because we're doing fluid balance, what we are overproduction of, you're not urinating, we are going to be monitoring daily weights, strict intake and output. Hyperthyroidism is a thyroid dysfunction. It's also called Graves' disease. It means too much thyroid hormone is being produced. It is usually as early teenager that you'll see, and we treat it unless it's, way too much. We'll be just treating it with medication. And one of those medication is polypripacil. Now, the problem with the prior polypripacil, one teaching that really needs to be done to parents is to know that they are apt to become leukopenic. Well, leukopenia, not enough white cells, you're going to be apt to be getting sick easier. So if a child is leukopenic, you're having fever, sore throat, we need to tell the physician to let him know. And we usually treat that with glucocorticoids, so with steroids. Now, if there's really overfunction, that's when we're going to do the radioactive iodine, and it's called ablation, and we're going to get rid of that thyroid. Now, you will be on thyroid replacement hormones for the rest of the life, because then there's no thyroid hormone going at all. Now, one of the side effects of hyperthyroidism is something called a thyroid storm. And it's basically all of a sudden thyroid hormones just released, and your temperature, you get feverish, you get a high temperature, high heart rate, flushing, tightness in the chest. It's a horrible feeling. And we treat this with beta blockers. And then this thyroid will need to be taken out, especially if it's more than one storm that this child has had. Hypothyroidism is just like adults. It doesn't matter children, doesn't matter adults. The only difference is growing, because children still grow. Hypothyroid children, if they're not getting proper replacements, are not going to grow as well as they should. So what will you see? Well, just like adults, dry skin, constipation, cold intolerance, yes. The other thing is little sparse hair. You're going to see dry skin, some puffiness, and then sleepiness. You're just really down and draggy, and you don't have the energy as much as possible. Remember, these children are going to be needing a hormone replacement that can, give them what they need. Adrenal dysfunction. Well, you can have too much or too little. Well, we know the adrenal gland produces cortisol and aldosterone, and Cushing's syndrome is caused by usually an external giving medicine, steroids that are given. Rarely do we see the body produce too much, okay? We can see it produce too little, but usually we don't see it produce, too much. And when we have Cushing's syndrome, there are some signs and symptoms that we will see. So it's big, red, ruddy cheeks. We will see hair in places that young children shouldn't have, maybe a mustache, maybe a little on the chin, in other places that, the child could be too young to have. You're going to see skinny little legs, but you're going to see really, they're not going to be emaciated at all. They're going to be big, round, pendulous belly. And the way that we decrease Cushing's syndrome, or, return it back to normal function, is usually we'll take the steroids and just wean them off, taper them off slowly. And then the red ruddiness, the extra weight, the hair, will all go back to the normal child. Neurological dysfunction in a child. So when we are assessing a child, it's always good to have a baseline. You get a child in, before we do any procedures, check the eyes, check the strength, see if they follow directions and squeeze hands and all of the things that we could do depending on that child's age. Now, some of the things that we do that can alter the function of the head is, head injuries for sure. That can cause some swelling in the brain. Meningitis, it's the inflammation of the meninges in the brain. We can do a lumbar puncture and actually remove some fluids, and that can change the function of the brain. That's why after lumbar punctures, we don't sit them up right away. We don't want them to get a headache. Cerebral edema, which is increased intracranial pressure, could be due to a head injury, could be due to infections. That absolutely, the extra pressure can cause changes. Water, hydrocephalus, too much fluid in the brain, and all that squeezing that's going on there can cause it, and also seizures. Now, seizures in children, is something that happens when there's this extra burst of electrical that goes on into the brain. We know the most common in children is febrile seizures. And one seizure does not denote epilepsy. It would have to be a progress of them. Now, our goal in seizures in children, we can't do anything while the child's having a seizure, except don't panic, turn the child on their side, remove everything in the bed and make it flat, pad the side rails, and protect the child from the environment. And of course, we are going to be monitoring, the time and what the child looked for. But in a seizure, it is always protection of them. Bed flat, remove everything, bad bedsides, rails. And, they said put something soft under their head. That would only be if they're on the floor and their head is moving. So you'd protect them. But in a bed, just take everything away. So the seizures all depend on, where they are. And there's all different sorts of seizures. There's blank seizures, blank stares. There could be just an eye twitch. All of these things could be labeled as a seizure. Now, as I said before, one event is not something that would classify your child with epilepsy. It is 2 or more unprovoked within 24 hours that will cause to maybe be on, given the diagnosis of epilepsy, and then maybe require long-term anti-epileptic drug. But as I said, most of these are febrile. Usually it is not due to an epileptic type event, and just monitoring temperatures. So again, what causes seizures? Infections, lesions, metabolic problems, trauma, malformations, genetic problems, toxic ingestions, and of course, again, those fevers. So some seizures are due to an illness, like the meningitis. Sometimes they have seizures, but there's no cause. We don't know why. There's no tumor. There's nothing. We're going to call those idiopathic. So again, the number one nurse's priority action when caring for this child is to maintain a safe environment. It doesn't matter what sort of seizure, whether it's febrile or a tonic-clonic, it doesn't matter. Protect them, safe environment. So our goal is to teach this to the parents that they can keep their child safe too. There are different sort of seizures, like I said. I think the most common one that we think of as a seizure is, we know there's a little eye and staring and febrile, but when we think of a seizure like epilepsy, we think of that generalized seizure or tonic-clonic seizures. When I was in nursing school, it was called a grand mal, okay? But this is described as moving flexion to extension and then posturing, jerking, and then usually foaming at the mouth. That is usually the type of seizures that we think of. And then, of course, there's the other types, but cerebral palsy. Cerebral palsy is a disorder which causes problems with the development of posture and movement, and it limits activity because of these jerky movements. Now, the one type of seizure, spastic, we describe it as poor control of posture, difficulty maintaining balance, and hypertonicity. I mean, those of you in my class, this is my Jonathan, and it's the smile and the spasming that goes on with it and the hypertonicity. And just because children are nonverbal doesn't mean that they can't express what their needs are. Head injuries in children, what happens and why do we get head injuries? Well, we know motor vehicle is always going to be top of the list for injuries in all sort of children's, but falls, bicycle, or sports-related events. We know that it takes a severe blow to cause significant damage. As I said, children are so resilient. It's these injuries involve the scalp, the skull, the meninges, and the brain, and it's the swelling which causes the issues. So those head injuries that you do see are from a fall, are fractures, contusions, and then those intracranial hematomas, epidural hemorrhage, and you'll see blood in the brain, which is taking space that the brain doesn't like. Sometimes it's all over, which is the hardest to work with. But some of the other complications you might see is hypoxemia. So you've had an episode where you've had no oxygen, which the brain likes oxygen to live. So without it, and depending on how long, brain damage. If we have an increased intracranial pressure due to this swelling in the brain. That can also have more complications. Infections, cerebral edema. Now, you have a child who's had a head injury, who's fallen, who has swelling, who has a hematoma in the brain, and you have increasing intracranial pressure due to the cerebral edema. Remember, the treatment to get rid of that extra fluid is mannitol. It's not furosemide. Lasix doesn't work with heads. Remember, mannitol. This is only head. Remember, mannitol, head. So that's what we give, and you see immediately, quick, dumping of urine coming out, which is getting rid of all that fluid there. So when we are monitoring a child who's had a head injury, they might be alert and, they're talking and they get tired and they want to sleep, because that's what children do. They like to take their afternoon nap. It's 10 o'clock at night. They want to go to sleep. So when we are monitoring this child with a head injury, it's really important to monitor certain things. Changing in their level of consciousness. Are they having like this amnesia? Like, is daddy coming? Or if they were hit in the head in a sports injury, did we win the game? Was I safe on third base? Whatever it was. Or getting restless. When you think restless, something's going on. There's pressure occurring there. They're acting strange, if they're confused. And if they get to the point of difficult to arouse, we know this is the head injury that is talking to us. Also, vomiting more than 3 times. So it's not just vomiting, it's like vomiting and vomiting. Headache increasing, bigger headaches, bigger headaches. These things are showing you that there's increasing intracranial pressure and there's going to be needing some intervention done. You see pupillary changes. You see that they're small, now they're big and they're fixed and they're not moving. Double vision, now they can't walk that well. And again, that headache becomes worse. And when a kid is sleeping and they wake up, they're telling you they have a headache, that is a severe headache. So what are we going to monitor with these kids? Well, of course, that level of consciousness is really important, and if they're acting strange or confused, if they're vomiting, but more than 3 times, if their pupils are starting to do different things, blur, double vision, trouble walking, complaining of a headache, wakes them from a sleep, and then a fixed dilated pupil is your emergency. We have this thing that we say, so what are the pupils? Are the pupils blown? Which mean, are they big, dilated, and not moving? We know something severe is going on in the brain, and this child's probably going to need immediate neurosurgery to clear and evacuate probably some bleeding that's going on. So a fixed dilated pupil is a neurological emergency. Nursing care of a spinal cord injury. You get a child coming in. Usually when we get these children, they come from rescue. They're already with neck braces. They're taped to a board. They're very immobilized. Your important goal is to keep that spinal cord immobilized. I gave my class a great example today of a child who had an angulated C5-6 fracture, and I was the trauma primary nurse, and my goal was that, because I even had to do an MRI, and the outcome was great because we were watching that neck closely. It was the difference between being paralyzed from the neck down or being a normal child, which that child is today, a normal child. Meningitis is something that can happen to children. They're coming in complaining of pain in their heads, that is really bad, and photosensitivity, all of the signs and symptoms. And we decide we are going to do a lumbar puncture. Now, many meningitises are viral. Okay, so it's just treating them Tylenol, Motrin, and waiting for it to go away. Now, when we do a lumbar puncture, it is so important because that cerebral spinal fluid is going to tell us, is there bacteria in there, which is white blood cells? Is the sugar low? Is the protein high? Is it cloudy? Is it milky? These are things that can help us to treat these children properly. So after a lumbar puncture, we remove some fluid. Be careful. If we let these kids get up too quickly, they're going to have a severe headache. So have them get up really slowly so that they do not, get these headaches. So make sure, if we can, keep them down for at least 30 minutes.
Professor Bogart,
Yes.
would we be looking for all of those symptoms, like all of those findings, like the white blood cell
No.
count, or could it just be like a matter of them having one?
No, well, usually with bacterial meningitis, you're going to see an elevated white count. You're going to see a milky fluid come out instead of, it should be crystal clear. And you will see protein high and sugar down. Bacteria loves to eat sugar, and then the protein is a byproduct. It stays high. You're going to see all of those in bacterial meningitis.
Okay, it just sounds like a select all that applies question. I wanted to clarify.
It's not, but you're okay. But great question. Thank you. So with meningitis, what is your goal? What is your priorities? Well, number one, IVs and IV antibiotics. We want to get rid of that infection, especially if it is that bacterial meningitis that we're looking for. Also, make sure we're looking for cerebral edema. Cerebral edema, we would see those same sort of things, the confusion going on, difficult to arouse, and you're going to see that amnesia type going on. Remember, cerebral edema, the diuretic, mannitol is the one that we're going to use to help it. These children who have cerebral meningitis, there's already inflammation in there. There's already a little bit of edema in there due to these inflammation. So we do not want to put any extra fluid on the head. So make sure this child, very careful intake and output, because we don't want extra fluid in the head, which can cause some more pressure, which could cause more problems. So antibiotics, and then when you're taking care of this child, do all in one little piece. Do not keep bothering the child every hour. Let this child rest. It's probably one of the most important things. We do what we call cluster care, minimal stimulation. So when we have increased intracranial pressure, always monitor for that level of consciousness. Look for that headache and that vomiting. That is showing you it's getting worse. And we know infants are easy because they have that big fontanelle that gets really distended, and we know that the pressure is increasing. A myelomeningocele is one of the most common causes of neurogenic bladder. And the reason is the meninges and spinal cord are pressed out through the lower spinal column, stretching nerves, breaking them. Then you don't have any nerves going to the bladder. And the nerves that feed the lower extremities are usually damaged. These children have sensory and motor loss of the lower extremities. Your goal is to make sure you are keeping those monitoring urinary function, because we can have a child, it doesn't feel that they're full, that they have a bladder full, and it can destroy the kidneys, can damage the kidneys. So we want to maintain those kidneys by monitoring renal function and also monitoring, for constipation, both of those things with myelomeningocele. Hydrocephalus is too much fluid on the brain, and it has to do with the way that the cerebral spinal fluid is produced and the way it's absorbed. And this brain who has hydrocephalus just can't, for many different reasons. So many times these children are given a ventricular peritoneal shunt. It's a tube that goes into the fourth ventricle, goes outside the head behind the ear, goes down the neck, in front of the chest, and into the peritoneal cavity. So these children will have their fluid draining for themselves. Number one, never touch that pump, because there's like a slight little valve pump there. You never pump it, you never touch it. Your job is to monitor circumference of the head to make sure it's not getting too big. So that makes sure the shunt's working. And of course, measuring abdominal girth, because that's where it's going to. Anytime you have a comatose child, your airway is always number one. And then, of course, taking care of them, preserving function, skin care. And then if a child is unconscious, they still can tell you they're having pain. So you see increased heart rate, you can, or they're getting agitated, you can probably say that this kid has a headache for some reason. Reye syndrome is a syndrome that's caused by giving them aspirin. The only time we give aspirin to children is for Kawasaki disease, right? And that's just to thin the blood for prevention of clots, and it's the anti-inflammatory for that vascularitis in there. But given aspirin to children, there are some right after flus that they're given, and there's some metabolic issues, and it can cause Reye syndrome. So the goal is, unless it's Kawasaki, never give aspirin to a child. So near drowning or submersion injuries, children love to go in the backyard, jump in the pool, and they fall to the bottom, and we find them there, unconscious. So we go down, pick them up, get them breathing. By the time rescue comes, they're running around. The thing with that is there is a delay in the symptoms that will show. Remember, they have had a hypoxic episode. They've, usually aspirated some fluid in, and there's been a hypoxic moment. So when you are monitoring a child admitted, and they'll be admitted for 3 days, 72 hours post-drowning, we'll be monitoring their respiratory status, because that was what was damaged in the drowning. So GI function, dehydration, signs and symptoms. Well, I think infants are the easiest to tell it with when they have a fontanelle. See a nice sunken fontanelle, this child's going to be dehydrated. And of course, the other things, children, actually, these infants, their eyeballs can go sunken into their head, and you can actually see them sunk, and you can watch them fill up as we rehydrate them. You're going to see elevated heart rate, decreased blood pressure. You're going to have decreased urine output, prolonged capillary refill. These are all things that we can see. So the GI tract is the area where we have a lot of fluid absorption that can go on. We know that in children, dehydration is probably the most serious thing that can happen. We can literally put a child into acute renal failure because of not enough fluid into the body. So when we're talking about vomiting, diarrhea in children, and that loss of a lot of fluid and other different things, we know that this child could have potential for electrolyte imbalances, and of course, that dehydration. So when you have a child who is vomiting, okay, how can you feed them anything by mouth? You can't. So what are you going to do? A dehydrated child who is vomiting needs an IV, or vomiting and diarrhea, and can't stop vomiting, again, an IV. When you're talking about diarrhea, you can give fluids to a child. Now, how would you know an older child? Are they dehydrated? Their heart rate's up a little bit, but not much. They still have capillary refill. Okay, well, the other way, as we are starting this IV on this child, is to do a little blood test, a metabolic profile. This is the most important information that will validate, yes, this child is dehydrated. Now, when we are giving fluid back to a child due to dehydration, we're going to give 10 to 20 mLs per kilogram. And we're going to give it usually within an hour, unless the kid has other issues, like a bad cardiac, would go slower. But remember, whenever you bolus a child fluid, never, never, never give dextrose. we're only going to give some sort of saline. Okay, so never dextrose, only saline. So pyloric stenosis and Meckel's diverticulum are two different conditions in the GI tract. So let's look at them. When you see a child who's vomiting and dribbling, that's just a normal sort of vomiting. When you have a young child, they're usually 3 weeks to 2 to 3 months, about that area. I think the hot spot for what I've seen in my career is 6, 7 weeks. They'll come in and they'll vomit like the exorcist across the room. What happens is they drink. It goes down into their stomach, and right before the small intestine, there's the pyloric valve, and it gets thick and muscular, and it's called stenosis, pyloric stenosis. And the milk can't get down there, whether formula or breast milk, it can't. So it fills up, fills up, fills up, and all of a sudden, boom, it comes out, and it will go across the room. Now, if this happens, what you need to do is tell the parent no more feeding. In fact, the first thing when I see vomiting a young child that's brought into my exam room, how are they vomiting? Is it dribble or is it forceful across the room? They say across the room, we know that this child needs to go for surgery. So NPO, and then we will go for, excuse me, an ultrasound. Now, the other thing that you can feel is right there about mid-abdomen, right below the xiphoid process, you will feel like a little olive. It feels like this little round little ball there. And that's that thickened muscular area. And they're like, yep, this definitely is a pyloric stenosis. So we'll send it over for ultrasound. We'll find it's positive. So now that NPO child, will start an IV and we'll keep that stomach empty and now wait for surgery. Meckel's diverticulum is this little flap of tissue that rips and it has a blood vessel in it. And it starts dripping blood down into the intestines. Many times it's up in the small intestines, but it's just red blood that you're going to see coming out of the child, but it doesn't hurt. There's very minimal abdominal pain and cramping, slight tenderness, yes, but it's painless rectal bleeding is what those key words are for Meckel's diverticulum. And they'll do surgery and they'll repair it. Appendicitis, I think one of the most common GI issues, in children, that that requires a surgical outcome. So your child comes in, right lower quadrant pain, McBurney point, rebound tenderness, everything you see in an adult, yes. And these kids are brought in and we're going to do an ultrasound. We'll find the appendix is inflamed. We'll schedule them for surgery. As soon as you understand this child's a possible appendix, make them NPO. You do not want to delay surgery on these children. If this child stops having pain, you can almost be guaranteed that this appendix has burst. It's ruptured. What is the problem with a ruptured appendix? All of this free debris and toxins from the bowels spews into the peritoneal cavity, causes pain to the bowels. They get angry, they're red, and post-op care is going to be a lot different. They still go to surgery, they still remove what's in there, but post-op treatment is different. Now, a normal appendix taken out will come out a couple hours later, they get clear liquids, something for pain, get them out walking, and they'll be home the next day. A ruptured appendix is going to be in for several days. They'll put an NG tube down into the stomach to take away those gastric juices because we don't want anything going down into those bowels. It's angry, it's upset. It's got all of this caustic material in that peritoneum that's irritating it, so we want it to rest. Also, nothing by mouth. We've got an NG tube in, so nothing to eat or drink. IV fluids, IV antibiotics. this child's going to get up out of bed because we want those bowels to start moving. So it's not bed rest. But the other thing is because we've had a ruptured appendix in the peritoneum, when they closed the wound, did it have good, healthy tissue to close? The chances for dehiscing this wound is big. So do wound care, not wound care, but frequently look at it. Make sure the wound is intact because it could be opening up. So make sure. And then, of course, for pain, give them something for pain, getting them out of bed. These children are definitely uncomfortable. Hirschsprung's disease is what we call a megacolon. Children are born with it. And one of the things that you will see is a child not having a stool for 24 to 36 hours after birth. And there's several diseases we look for, but Hirschsprung's is one of them. And Hirschsprung is an aganglionic area in the bowel, which means there's no nerves. So the fluid comes down, whatever they're swallowing, the normal secretions, and it balloons up. But because there's no nerves, it doesn't hurt. Now, if you look at the bottom of that picture, there's like the tiny little strand that goes to the anus. So you might have a little bit squirt out, but it looks like a little ribbon, okay? Then when we say, all right, do an x-ray, it looks like this is what it looks like. We go and do a rectal biopsy, shows that there's no nerves, and we'll do surgery. They do a temporary colostomy to get rid of that aganglionic, which means it's worthless, it doesn't work. Take that piece of bowel out, then we let it rest, and then usually within the first year, they'll close up the colostomy again. So the child will have, normal bowel functioning. So more things, hepatitis, celiac, malabsorption, and now reflux. So hepatitis A, one of the biggest things is with hepatitis A is wash your hands. Now, if you have a child who does have hepatitis, one of the things is we know children, nutrition, growing is important. Nutrition. They need to grow properly. So they need a good diet. And what they need is high carb and high protein. Now, if it's hepatitis, it's the liver. The liver secretes bile. The bile digests fat. So there's no fat digestion. So low fat, because you don't want all that gas, all that distension. It's painful. So hepatitis, high carbs, high protein, and will give all the calories they need, and it will prevent muscle wasting because of this hepatitis. Celiac disease is an autoimmune of the small bowel. It has to do with the inability to deal with gluten in the body. Gluten is wheat, barley, and rye. So everything that has bread on it, breading, chicken nuggets, noodles, spaghetti, all of those things need to be avoided unless it is gluten-free. So what would you eat? Well, an egg, a glass of milk, fruit, piece of bacon, ham, all of those things can be eaten. So protein, fruits, and veggies are perfect, and I'd like a nice omelet for this morning for dinner if I had celiac disease. So wheat, barley, oats, rye, everything to batter food, we shouldn't have it. And the best thing to do is to avoid, these sort of foods. Now, when you have a child with celiac disease, you are going to see that they do not absorb fat. You're going to see these loose bowels, pale, and you're going to see a lot of smell from them. And the problem is they're not getting all the nutrition they need. So we have to be very careful with nutrition with these children. Other things that can cause problems with malabsorption, when you talk celiac cystic, we're talking about fats and not being able to absorb them, and our body needs it. So we're going to need replacements. We talk lactose, there's no milk, and pancreatitis and insulin and all of these things affect the way that the body absorbs food. I mean, if we have not enough vitamin C, it's called scurvy. If you don't have enough vitamin D, it's rickets. And then we have marasmus, which is a problem with calories and proteins not being enough. So remember, as we are looking at children, nutrition is important, and the lack of vitamins can cause damages to these children, especially vitamin D. And you have osteodystrophy, which can occur, which, will deal with not enough growth. Children will be smaller. GI reflux, GERD, whatever you want to call it. This is when you have food that goes up the esophagus. Now, an infant's very easy to tell. You will have a child in your lap, you just fed them, and you'll watch their back arch. And you can actually feel, just by the way they arch, the milk going up and burning into their esophagus. So with infants, you'll put them on medicines just like adults, but we're going to put them on pediatric doses, milligrams per kilogram, micrograms per kilogram, and they do work. First thing we'll do is make sure that they're, the gas is gone, that they're burped properly, that they're not being overfed, that they're sitting up after foods. And if not, then we'll put them on the medicines. Now, children that are older can have reflux. Usually these children will present with things like this cough for no reason. They're not sick. And they're complaining of burning, epigastric abdominal pain, chest pain, and recurrent pneumonia. What's happening? We're aspirating. Now, children who have reflux, and they're having all of this, fluid going up and down, and these chronic, pneumonias due to reflux, they can think about doing a surgical procedure called a Nissen fundoplication. And what they do is they sort of pull the top of the stomach up, and it prevents reflux on these children. So it is a surgical intervention, but it takes care of this reflux and prevents, damaging the lungs with this chronic aspiration pneumonias. So a Nissen fundoplication. You'll also see that too when we put in G tubes, because of the amount of fluids to prevent aspiration again. So GU dysfunction, things you need to know about, a lot of different diagnoses. So urinary tract infections is one of the things that we see in children. We know that newborns, they could have other malformations that are going on, so that we can, check for that. We know that if we see a child who's age of 8, who's still having bedtime wetting or enuresis, something's wrong. We need to investigate it. That is more of a significance than a 4-year-old. And we know that some children who are not growing it could be also because of their kidneys. The kidneys play a big event in the growth of children too. So what do we do when we see chronic urinary tract infections going on, and we see, things like enuresis? Well, we're going to be doing examinations. One of the most popular that's done is called a voiding cystourethrogram, or VCUG. That is the abbreviation. And what it does, it looks at the bladder. We put a Foley in, put dye in, and see if it refluxes up the ureters, goes in the kidneys, if there's obstructions. So it's a very good test to be done. It's an outpatient procedure in the hospital, and it does really show a good telltale sign of what's happening. Children can be with renal failure, chronic renal failure. Chronic renal failure in children is due to many different things. It could be hereditary. It could be due to these obstructions that are not fixed, or chronic infections. So when you think of a child, even adults that have chronic kidney disease, you know that they're always going to have low blood counts. Now, the way to treat low blood counts is to give them transfusions, but there is medicine called erythropoietin. And what it does, it increases the red blood cell production, and it's given to these children as a sub-Q injection, and it decreases the amount of blood transfusions that they do need. The other thing that we can do, and usually it's on the smaller children, though they're giving it more to older children now, but they're starting peritoneal dialysis. Now, peritoneal dialysis is we use the peritoneal cavity as a kidney because the kidneys aren't working. So we'll put in a catheter. We will put them on a machine with warmed solution that goes into the abdomen, and it pulls out toxins, and then it's dumped into a Foley catcher, and we will filtrate, and we've done this at night. Parents do this at home, and I've seen some do really, really well. Now, one of the big things with peritoneal dialysis is that your peritoneum, this baby's peritoneum, is the only thing they have to filtrate to do what the kidney needs to do. We need to protect it because the big side effect is peritonitis. Hooking up and taking off this equipment can cause the entrance of infection. So how would we know if there's peritonitis? Well, if we're doing dialysis, we're putting clear fluid in and it starts changing color, it's getting cloudy, it is, a different color, it's got sediment, call the doctor immediately and get this child on antibiotics right away. So cloudy diastolate drainage, probably it's infection, peritonitis, we need to get it and check right away, call the doctor, get your antibiotic. Nephrotic syndrome. Now, nephrotic syndrome is not renal failure, and I'll say it again. Nephrotic syndrome has nothing to do with renal failure. Your kidneys are working, but it doesn't know what to do with protein. So what do you see? You'll see a child who is urinating, but have a whole lot of protein in it, so proteinuria. And the protein is also pulled out of the blood, so hypoalbuminemia. When we see hypoalbuminemia, fluid gets pushed into the interstitial tissue. So you're going to see fluid and edema on these children. So again, we're talking fluid problem, nursing issues, daily weights, intake, output. And these children also decrease the salt on this. Whenever you see anything edema, nursing, priority, please be careful. It is all about as simple as daily weights and intake and output. Acute glomerulonephritis is the other diagnosis that's caused by an under or not treated strep infection. So acute glomerulonephritis, you're gonna have a child present where they're not urinating, and they're not urinating, which means what? They're swelling up, they're gonna get swollen. Extra fluid causes the blood pressure to go up. There's going to be congestion, fluid in the lungs, then you'll see hematuria, and then you're going to see proteinuria coming out. How do we treat acute glomerulonephritis? Well, it's from an infection that wasn't treated. So we're going to start treating that infection and treat that strep infection. And usually we can turn the glomerulonephritis and we can eradicate it. On a rare occasion, it becomes chronic. So urinary tract infections, a lot of times it's due to little girls, little short urethra. It's due to wearing tight underwear, polyesters, not urinating enough, holding the urine, constipation, and bubble baths. I mean, poor little girls can't take bubble baths because it can enter that debris up into the bladder, causing urinary tract infections. When we see a child starting with frequency is when you'll see them burning. We know that probably that's what's going on. One of the ways that we can help prevent this is to increase fluid intake and make sure that they empty their bladder as much as they can. Some congenital abnormalities that can happen to males. Hypospadias is opening. Instead of the urethra coming out the end of the penis, it comes at the bottom. So the epispadias is when the opening is on the top and not out the end. And what we do is, if you look at that picture on the right, that baby laid there with, there's a little stent hanging out of there. And what they do is they take the foreskin and they do a plastic procedure. And it's under general anesthesia. They put in this stent, which will hold that area open, keep that inside patent, and they'll send it home with that tube in there. And we just leave it alone. We don't touch it, okay? It's just there. We just change the diaper and just be careful with it. And these children do really good. They usually do it before potty training is when the goal is. Usually at the end of the first year is when they like to do that. The cryptorchidism is when the testes are way up inside and they don't come down, either one or both. Remember when we're going to look for this, you know, the pediatrician sits there and looks for the testicles. Now, if the room is cold, they could suck right up in there because that's what boys do. Their testes will suck up. So if we want to examine it, make sure it's a warm room so they'll be down and we can have a really good examination, not so false, it's still upside, you know, inside. And hydrocele is just fluid in the scrotum and it hurts actually. And that's what usually brings the child, mommy, it hurts down there. And it's an infection and they'll give antibiotics. Acute kidney trauma is somehow you've hurt the kidney, whether it's car accident. I mean, the one, I've seen it once only in my life. And it was a little boy who was running around playing tag, you know, outside, and there was a trailer with a huge hitch on it. And he turned around the corner and was going backwards, and the hitch hit him right at the level of the kidney. And there was a huge, the whole side of his back had a huge bruise on it. So what would you see if that child let that prolonged? Is you're going to see them stop urinating. Okay, that's one of the big things that you see with it. The thing with kidney trauma and the thing to monitor to look at the severity is looking at the potassium. And whenever you think of kidney, we know all kidney things, acute kidney failure, chronic kidney failure, we watch potassiums. Well, in trauma, we're going to be watching those potassiums also, because that's telling you that we need to really monitor urinary output, intake, output, daily weights. Now, sometimes we need to go in because there's something going on with a kidney. Maybe there's a lot of infection going on, or, you know, they need to get some tissue to look at it to make a diagnosis. So they need to go in with a big needle into the back and pull out a little tiny piece of tissue. Now, usually we do this in a procedure room. Kid will be usually sedated for it. If it's a child who cannot be sedated and will wiggle too much, you know, they will do more than a little bit of sedation, like a conscious sedation. These children will be made NPO 4 to 6 hours before, depending on the age of the child. Younger children get less NPO than older ones. And then they'll either be sitting up or on their side. Physicians are all different. And what they do is they stick the needle in there, get their little piece, pull it out, and then put big pressure there. Now, they've gone in and they have touched the kidney. So you could have urine coming out on the outside into the dressing or on the inside into the peritoneal cavity. So what is our nursing care? Well, they're going to be in bed for 24 hours. It's just like cardiac cath. You don't want them to pop that little clot that's there so that urine will come out. So you can have a nice big pressure dressing, sandbag if you possibly can, monitoring those vital signs. We're going to be looking to make sure that their belly is good, that it's not getting tender. If it's getting tender and pain, we know probably urine is going into the peritoneal cavity. And we're going to, of course, because we've touched the kidney, what does a kidney do? It puts out urine, so we'll monitor intake, output really closely. Kidney transplants are done when kidneys don't work well. Rejection is the most common of all transplants, and they all will be placed on immunosuppressant therapy. Also, erythropoietin is given to these children too to increase their red blood cell production, and of course, any anti-rejection things. So what would you see if you saw a child, with rejection? Fever, swelling, the kidney transplant, so it's not going to work. So diminished urinary output, blood pressure go up, and so will the serum creatinine. So maybe a nursing diagnosis for a kidney transplant patient would be risk for infection related to immunocompromised state and post-transplant medications, very simply. Fractures in children are due to many different things. We know that if it's an infant who has a fracture, we really need to follow that up, check it out closely to see if it might be abuse, because it could be. We know that the forearms, the radiator and the ulnars, most common. Usually it's bike sports injury. When we look at the type of fractures, we have either they're closed or they're closed with multiple bone fragments or different sort of fractures inside, or if it's the one that the bone is coming through the skin, this is what we call an open or a compound fracture. The thing with the open or compound fracture, because we've exposed that bone, this child will require antibiotics to prevent an osteomyelitis. So types of fractures in children, they could be buccal, green stip complete. It doesn't matter that sort of fracture. Our goal is to make sure that we put these bones back into position so that function can be there and so that we're not going to have any deformity with it. So doesn't really matter that sort of fracture. The only fracture that makes the biggest difference is the growth plate, the epiphyseal plate, making sure that that is prepared and lined up properly so that we do not have a shorter arm or shorter leg or a crooked arm or a crooked leg. There's a green stick fracture. It's basically sort of like a twisting and it's sort of bendable. It's basically called a green stick, and you can see it's like a green branch, the way that you would turn them, they would sort of mold a little bit. So when we put a cast on this child, whatever sort of fracture it is, if it's that open type of fracture, we will probably have a little hole right where that open area is so that we can monitor to make sure that there's no infection. But pain, if they're getting more pain that's not relieved, something's going on. Pulselessness, of course, there's no blood flowing. Pallor, again, should be pink. If there's no skin, if it's pale, we know blood's flowing. So again, there's something happen. Paresthesia, tingling, burning, paralysis, pressure. This all means that blood flowing is not correct. This cast needs to probably come off, or windows or part needs to be cut off, because if we are not putting blood into the arm, the leg, it could cause necrosis of the tissue, could cause the arm or the leg to literally die inside, and you can't see inside a cast. Cast care, when we have it done, should be kept up on a pillow. You shouldn't be pushing little holes in it. Let it be out to air. That cold hair dryer sometimes really helps. Moving the little fingers, and these children should be resting, for at least the first day in order to let that initial bone that are put together to allow it to heal properly. They should keep it elevated because you don't want the swelling to go on there, whether it is the arm, if it's the leg, you want to put the leg up as we can. Nothing inside, no hangers inside. You can really cause some damage. You can see they could scratch the skin, cause an infection. If they're on crutches, please make sure that the pathways are really clear and that the crutches are appropriate to the child. And then there's sort of tractions. There's skeletal, skin, and cervical traction. And what the traction does, the purpose, is to relieve muscle spasms, because especially if you think of the fractured femur, and you've got, it's fractured in half, and there's little sharp edges, and it's touching into the muscles and nerves, it's causing spasms. So if we pull it and put them back together again, and because it's being pulled by this traction, it's alleviating pain, it's realigning it, and it's going to prevent contracture deformities. Remember, when we have these tractions, especially the skin for a which is called a Buck's traction for a fractured femur, that we make sure the weight stays there, that it's free hanging, so that if we take it off, we're just going to make that bone move again, and we're going to cause a spasm. We don't want to do that. So keep it hanging free, you know, moving the way it should, and document the weight, how many pounds are on that once a shift. So there's Bryant's traction, it's a skin, Buck's traction, and halter traction. That hasn't been used for a while, but you know, years ago, I actually had that for a cervical injury. So again, here we are, the Buck's traction. It is a little thing attached to the lower leg with a little boot, pulls, goes over a pulley with a weight hanging. Make sure it's unobstructive, make sure it's moving slowly. Again, document those sort of pounds of weight that are there on your shift. Halo tractions are with things that could, they're attached to the skull. They're to keep the neck, you know, immobilized so that healings can go on. The tongs are done. They're laying in bed. It's being pulled. It keeps that cervical spine immobilized. And sometimes if we put them on traction, they don't need surgery. Sometimes you put them on traction waiting for surgery, but many times it can help heal what's going on if it's not that severe. And then scoliosis, just think of scoliosis, think of S curve. And it's an S curve. And when that have that area that's, you know, the angled, we know that's pushing up against the lung inside there. So we need to do something to try to straighten it. Now, usually scoliosis, we might see it at birth, or it might, you know, present itself during childhood, but usually during that pre-adolescent growth spurt is when it really becomes evident. Now, if this is a angular, is less than 40%, what we're going to do is put these children in a brace. Now, remember, this is an adolescent that we will see this after that pre-adolescent growth spurt is when we treat these things. We know body image, and you don't want to, you know, be different. So we know that we can make these braces, you know, cool looking and different sort of materials that can be used. And the children's do that. 23 hours a day, it must be on there. So 23 hours a day, we put a t-shirt under something underneath, then we put it on, and then it's exercises and physical therapy, strengthening the back. And we can many times not need to do surgery. If we need to do surgery, it is that with more than 40% angulation on the curve, and they can do a Harrington or a Luque rods, and it's basically putting rods down the back. And you can see with this child, it's not completely straight, but it's a lot better than what it was. So again, this curves 25 to 45, it's the bracing, and it's usually after that. So if you have 50%, you're going to go to surgery. Again, trying to make it look cool. You can see these girls have some really cool braces looking down there. And of course, with their body image, again, that diagnosis for nursing would be disturbed body image, because these children it's saying it's an appropriate nursing diagnosis, because they're such into body image, and their body image and lack of, feeling good about themselves causes, a lot of depression, etc., with those adolescents. Osteomyelitis is an infectious process in a bone. And you will see a child, redness, pain, swelling. It may not be as much as this toe right here, but it could be just a slight little red streak. Remember, osteomyelitis is an entry of some sort. Something happened and staph got in there. So it is a staph infection. The thing with the staph infection is hard to cure. It's hard to get rid of. So these children will be on some sort of central line, like a PICC line. They'll be on antibiotics, and the antibiotics for staph is what? Vancomycin. Vancomycin is an aminoglycoside. So you have to be very careful about kidney function with these children. And then it's peak and troughs and monitoring all of those lab values to make sure that we're not damaging, hearing and kidney function, because those are the two things. This child's going to be immobilized, they're going to be on bed rest until it's cleared. And the big thing, again, with children, you'll see it again and again, nutrition. High protein meals for these children to aid in muscle, stopping muscle wasting on these children. There are times, if we don't catch it quick enough, they need to go to surgery. And if they have to go to surgery, they might have to remove a piece of the bone, might have to remove a whole limb, a whole foot, a whole toe, depending on it. But I've never seen it, but it is if we don't catch it quick enough. Lupus, autoimmune disease that loves organs. So when we're looking for lupus, what will we see? Well, we're going to see that little rash of some sort. It's not always the cute little butterfly rash. It could be something different. That's why I got some different pictures here for you. They have photosensitivity. They can have oral nasal ulcers. They can have muscle aches and pains, kidney problems, and goes on to hematologic, immunologic, and ANA antibiotics issues with there. So in lupus, we do give certain different medications. They can be on steroids, depending on the severity. And the thing with lupus is to prevent exacerbations, to prevent those flares. And one of the things is making sure that we use sunscreen on these children and decrease the amount of sunlight, making sure that they are in compliance. And children who have lupus do need prophylactic treatment before procedures, like dental procedures. They need some steroids, which they're on usually, but an extra dose, and then prophylactic antibiotics. These children should be somehow, whether it's a tag or something, to let people know they have lupus. Now, the other side of this autoimmune is JIA. This is the autoimmune disease that loves to attack joints. It limits joint movement in the morning, stiffness, pain, hard to walk, stand up. It does affect growth also with these children, and it can affect the temporomandibular joints here, and it can cause the chin to drop down there too. So we treat these with NSAIDs and exercise. It really does help. Guillain-Barré, it is a viral type thing that attacks the nerves, a polyneuritis. And it usually starts 10 days after a viral infection. It starts from the feet and it works upwards. Symptoms are usually that shuffling feet, falling, numbness of the feet. You can see these different viruses you see here. They do say some vaccines. I was watching a program that actually, one of the influenza vaccines, and usually it doesn't cause it, but it was one of these super rare things. It's watching House or one of those things. Symptoms of Guillain-Barré, as I said, it starts from the feet. Okay, so let's start with waddling gait, leg pain, late weakness, pain in the toes. And then it starts moving upwards. You might see incontinence, constipation. Your biggest goal, because this is nerves, you have the phrenic nerve that makes the diaphragm work. If the diaphragm don't work, you don't breathe. So priority care is watching that respiratory, making sure that the lungs are working, because all of a sudden they'll stop breathing. These children do require to have a respiratory care, intubated, maybe even a trach. It can be a couple weeks, it could be a couple months. Every child is different. So how do we treat Guillain-Barré? They are saying probably the best is the IVIG. You might have steroids in there, but they're saying IVIG for sure. And we need to try to give it as soon as we know it. You will have 5 basic dosage calculations, not unlike any of the other exams you have, but they're going to be different numbers down there. So good luck, keep studying. Anybody has questions, want to meet with me one-to-one, just let me know and I'll help you. Any questions? A lot of information. I wish
Thank
all
you so
good luck.
much.
Thank you.
You're very welcome, guys.
Thank you.
Thanks. Have a good night.
Thank you. Have a good night.
Thank you. Good night.
I'll
Good
have this
night.
posted by tomorrow morning.